Good afternoon. Good afternoon. Welcome to this month's Children's Caucus. Before we begin, I would like to extend a thank you to Leader Rousseau for her leadership co-chairing the Ohio General Assembly's Children Caucus over these past 3 years. I'm grateful for her service to the caucus and her commitment to improve the welfare and quality of lives for Ohio's youngest and most vulnerable citizens. I know that myself personally and the rest of the Children's Caucus all wish her the best in her new role as leader. In addition, I would like to welcome Representative Smith as the co-chair of the Children's Caucus. Representative Monique Smith and I met in my office a couple of weeks ago to discuss the work of this caucus, and I really enjoyed getting to know her personally, hearing about the issues that she's passionate about, and also I just wanted to give her a heartfelt welcome to work together on these important issues. I don't know if you wanted to say a few words, Rep. Smith.
Thank you so much, Senator Kunze. I will just say hello and thank you so much for the opportunity to partner with you as co-chair. I enjoyed speaking with you as well, and I know your commitment to the issues that this caucus works on is sincere. As we talked about in our conversation, while the issues surrounding children and families in Ohio are always important, we know that the pandemic hit children and families especially hard, causing them to suffer a number of consequences in the area of social development, education, and economic consequences. And so we know that we need to be focusing on how to get families back on their feet coming out of the pandemic. And I look forward to working with you and with everyone in this caucus to lift up those issues and make Ohio the best possible place for children and families to live. Thank you for the opportunity. I'm excited about this.
We're so grateful to have you. Next up, this February 28th meeting topic is improving oral health care access for children and families. According to the 2017-2018 Oral Health Screening Survey of third grade school children, getting dental care remains the #1 unmet healthcare need among Ohio's children. Overall, wide disparities in dental health care access persist in our state, especially among young children whose households have the lowest incomes and those living in Ohio's Appalachian counties. Yet, oral health is inextricably tied to overall wellness. Poor oral health poses negative impacts for mental health and can lead to various diseases and chronic conditions that decrease lifelong health and well-being and prove costly to our state's healthcare systems later, such as cardiovascular disease, adverse pregnancy outcomes and birth complications, certain cancers, and respiratory conditions. While barriers to care exist, it is imperative our state promote greater oral health equity among our residents, making sure children and their families get dental care when they need it. In recognition of National Children's Dental Health Month, the Ohio Children's Caucus will be hearing from an expert panel on opportunities to improve oral health care access for Ohio's children and families. Today, I'm pleased to introduce the following 3 guests. We will be hearing from Marla Morse, representing Oral Health Ohio. We will be hearing from Dr. Paul Casasimo, representing the Ohio State University College of Dentistry. And we will be hearing from David Merware, representing Ohioana for Dental Equity Coalition. Marla, thank you for being here, and you can kick it off when you're ready.
Thank you. Good afternoon, everybody. I want to thank the caucus chairs for the invitation to present today on this important topic. In the next 6 to 7 minutes, I'm going to be giving you a high-level view of the importance of oral health to overall health, briefly go over a few metrics on the oral health status of Ohio children. Dr. Casamassimo will give you a deep dive on that, and some of the key system-level factors that contribute to oral health disparities. Next slide, please. Oh, that was the slide I went. Okay, next slide, please. Thank you. Thanks. When we talk about children's oral health, it is important to have a lifespan perspective. This is because the community conditions, also called social determinants of health, and barriers that delay and prevent oral health in childhood, especially among low-income children, persist into adulthood. The social determinants of physical and behavioral health are the same for oral health. Tooth decay in children is a chronic condition that can last into adulthood with new costs and consequences. These costs and consequences will be shown in the next few slides. It is important to note that children with special healthcare needs and chronic conditions frequently face a lifetime of poor oral health and frequently lack the resources to access appropriate care. We will see on the next slide why a lifespan perspective highlights the importance of an adult dental benefit in Medicaid. Ohio is one of fewer than 25 states with an adult dental benefit, and I want to take this opportunity to thank all of the members of this caucus for your continued support of an adult dental benefit in the Medicaid program. Next slide, please. Oral health is health. This slide shows some of the impacts of poor oral health on our bodies. From a lifespan perspective, this slide demonstrates the potential consequences in adulthood of chronic childhood decay and why an adult dental benefit in Medicaid is so important. Next slide, please. Oral health is also well-being. Oral health and behavioral health are closely connected. In children, poor oral health can impact their ability to thrive, chew, speak, smile, develop social relationships, and concentrate at school. With chronic tooth decay comes chronic pain. Children cannot learn or sleep when they are in pain. Behavioral health, such as substance use disorders and medication to treat mental health conditions, also has an impact on oral health. Next slide, please. The oral health of children begins with pregnant mom. Preventive dentistry during pregnancy is safe and effective. However, you can see from the 2019 Ohio Pregnancy Assessment Survey that we need to do more to educate women about the importance of oral health for themselves and their unborn child. This education begins with primary care providers talking to their pregnant patients about the importance of oral health during pregnancy, and is also an opportunity for care coordination to an oral health provider. Next slide, please. Ohio performs above the national average on preventive dental visits and dental sealants. A dental sealant is a thin plastic coating painted on the chewing surfaces of teeth. The Ohio Department of Health school-based sealant program is a successful model in applying sealants to low-income children. Next slide, please. Preschool age children with a history of tooth decay and untreated cavities is a serious problem in Ohio that Dr. Casamasimo will be talking to. Next slide, please. Thank you. This slide demonstrates the social, emotional, and economic costs of chronic tooth decay in children from childhood to adulthood. From a lifespan perspective, you see that chronic tooth decay in school-age children can lead to absenteeism, academic and career readiness, and mental health challenges. These factors can lead to high school dropout, which can put children and adolescents at risk of economic well-being as they enter adulthood. Next slide, please. Now I'm going to review some of the system level factors that contribute to oral health disparities and oral health outcomes. First, current payment approaches in traditional clinical practice favor volume over prevention. A strategy to address this factor is to develop payment models that prioritize prevention and health outcomes over volume of service. Examples of alternative payment models are Medicaid's Comprehensive Primary Care for Kids program and Oral Health Ohio's value-based integrated care pilot, which will be implemented later this year. The goal of the quality metrics within the CPC and Oral Health Ohio pilot are intended to lead to decreased costs in care and improved population health in children. Oral Health Ohio will be sharing with legislators the pilot sites in their districts once sites are identified. Second, oral health is siloed from overall health as well as health information. Currently, medical and behavioral electronic health records do not communicate with dental electronic records. According to a 2019 survey by the CareQuest Institute for Oral Health, 70% of providers could recall an instance where access to medical or dental information would have improved patient care. Integrated care, such as having a dental hygienist embedded in a pediatrician's office, is a strategy the FQHC system in Ohio is currently using. Finally, to improve health equity, we must bring care to people rather than insisting that people come to the care. School-based health centers are an excellent example of bringing care to people. School-based health centers are a powerful tool for achieving health equity among children and adolescents and has a strong focus on disease prevention. School-based health centers are also open to anyone in the community. I personally have commercial insurance and receive my dental care through a school-based health center in Cincinnati at Withrow High School with Dr. German Bazan. Next slide, please. Finally, the pandemic has exacerbated health disparities, deepened the dental workforce shortage, and put stress on the dental safety net system due to the volume of patients who delayed care during the pandemic. I look forward to your questions, and my contact information is on the next slide. Thank you.
Hi, everyone. I'm Paul Casamassimo. I'm a professor emeritus at Ohio State University and continue to work at Nationwide Children's Hospital here in Columbus in the Department of Dentistry. And I want to embellish some of the things that Marla talked about and talk about some of the things we need to do in Ohio. So can I have the next slide? So to cut to the chase, we have some strength here in Ohio. As Marla said, we have a great sealant record to prevent tooth decay on permanent teeth. Our Department of Health has great surveillance, as always, for the last 30 years that I've been here, provided us with up-to-date information. And then we've made some headway, and we've met or exceeded national 2020 goals for oral health. So we've done some good things. We still have some work to do in early childhood caries, both in prevention and treatment. Talk more about that in a second. We also have not adequately addressed the oral health needs for minority populations and those living in rural areas. So we should think about working on that. And then our participation in public programs is limited, and we need to get more dentists in the dental community and hygiene community involved in care of those who need it most. Next slide. So these are the good things. The children with history of tooth decay compared to national average, we're doing just as well. Remember too, though, that that's a goal, and it means many are behind the goal and could always do better. We have a percentage of children with untreated tooth decay, which means they have not been to a dentist or still are having difficulty accessing care. We're better than the national average, and we should be proud of that. The dental sealants, Marla talked about that. We're a national poster child for that. We've done so well. And then we have most of our kids eventually get to see a dentist, whether it's for checkup or because they have tooth problems. Next slide. So I want to talk about two groups. One group is the preschool population, and this slide talks a little bit about that group. If you look at the lower left, that's what a child's mouth looks like in about 23 or 25% of children, preschool kids in Ohio. So we still have a lot of tooth decay to take care of. And again, in the bottom row, you can see about 14% or 1 out of 7 children still has tooth decay. These are preschool kids now. These are kids who don't have the ability to express themselves, and as Marla pointed out, suffer some significant consequences because of their tooth decay in terms of development, being able to eat, to communicate, to attend school, and so on. And then the one that always troubles me is the fact that 1 out of 10 of these children has had tooth pain. So they've got to deal with a whole bunch of issues in many cases in their social system, but also have to deal with tooth pain that keeps them up at night and causes dysfunction in their family because parents can't sleep and get ready for work. Can I have the next slide? So this is a national problem that is also present here in Ohio. Let me explain this slide on the left. We did a survey of the states in March of 2020, right before the pandemic started. And if you look at that, the question was asked, are you experiencing difficulty getting children and special needs patients into the operating room? And you can see the tan response, which is a yes, was about 2/3 of the states reported that, in fact, their ability to get into an operating room to safely treat their patients for dental decay, like the slide I showed earlier, fixing those teeth, or in worst case, extracting them, was a pretty significant problem. And that problem was not new with COVID. It started before, but COVID dramatically exacerbated it. So fast forward in December of this year, or the past year, a couple months ago, we did a follow-up survey, and you can see the dark blue are states in which it's gotten worse. Ohio, fortunately, has not gotten better, but it's not gotten worse. So this is a serious problem. These young children, the alternative is that we hold them down and treat their teeth. Some of them are 2 years old, not even 2, 3, 4. They don't understand. Some end up in emergency departments with swollen faces that can be life-threatening in terms of closing off their ability to breathe or disseminating their infection. Many of them have problems with something that very few of us are even familiar with, and that's Tylenol toxicity. Their parents are forced to give them Tylenol or some other pain medication day in, day out, so they can sleep through the night because they can't get their teeth taken care of. And this leads to liver damage. And those of us who work in children's hospitals in Ohio know that that's a very common finding. So this has not gotten better. In fact, it's probably gotten worse here. It's just not reported yet. So that's something to think about, is these children, these very young children, are really susceptible to a lot of issues. Next slide. So I'm going to move up to third graders. Our Department of Health does a wonderful job surveying third grade children. And what you can see here on the left set of columns, the taller ones, is those kids who have had a history of tooth decay. And the columns that are important are the far left blue one, which are children who are poor. They qualify for school lunch programs in our schools. Compared to that light tan group that is those not enrolled, those who have reasonable resources. So you can see it's a pretty significant difference. And then again, the rose-colored of that tall are the kids in Appalachia, and compared to the purple group, the kids who are not in Appalachia. So poor kids from rural areas are particularly affected. They have a history of tooth decay. They may have been treated, but that's a pretty significant percentage. It's well over 1 out of 2. So if you look at the right side, this shows teeth that need to be fixed or taken out or treated, and infections taken care of. And once again, the same colors apply, and you can see that those who are poor and those who are from Appalachia suffer the most. Could I have the next slide? So compared to the United States, we're kind of right in the ballpark. In the middle set of columns, you can see that in terms of untreated decay, we are worse than the United States average. We have many children who cannot access care. And again, this is third graders, but it probably accounts for most of our children in terms of the same set of circumstances. So we're not doing as well as the national average. We could do a lot better. Next slide. This is another aspect of the Appalachian experience in terms of oral health. And you can see, again, it's a repetition that you look at the top right side, kids in Appalachian, not quite double the untreated caries rates or tooth decay rates as the rest of Ohio. So it's pretty significant. And the issues are multiple. It's poverty, it's access to a provider, it's cultural, dietary. You can see in the lower left, that's a pretty significant difference in terms of the amount of sugar sweetened beverage exposure and other aspects of diet that affect these kids. And so there is a sense of dental fatalism in parts of our state, inner city and rural areas, where it's expected that a child will get tooth decay and suffer because it's always been that way. Next slide. So what can we do? Well, we can ensure access to care for low-income children. We have programs that do that. We need to have dentists involved. We need to have our systems work to be able to bring patients and families to the system. We need to address this operating room difficulty and make sure that those kids who need it, the youngest of among us and those with disabilities, have access to operating room care. Another thing we can do in terms of prevention, which I haven't really talked much about, is our physicians see these children, all of our children usually, in the first 2 years of life. We could do a much better job with the relationship between our physicians and our dentists to make sure that someone is looking at these children and getting them to a dental home, providing them optimal fluoride. And then we can improve our incentives to get dentists to go to rural areas. We have some good programs for loan repayment, but we could do a lot better, and we could incentivize the dental community to go into areas where they're not. Water fluoridation has been proven as one of the top 10 public health measures in the history of health, and so we need to continue to do that. And then those safety nets, we have a number of safety nets in our state. These are privately funded philanthropic clinics that run, and they depend on compensation from our system. And we really need to figure out ways to nurture them because they are the backbone of our system for the poor and the underserved. Okay, I think that's it for me. Thank you very much.
Thanks, Dr. Cassim-Simo. It's good seeing you again. My name is David Mayware. I'm a consultant with the Ohio Public Health Association, and my job today is to kind of fill in a couple of different places in the presentations that have happened so far. I really appreciate Marla's presentation on data and what's happening in Ohio. It was really great. Thank you, Marla. So let's go to the next slide. First of all, I want to give you just a little bit of background on the Ohio Public Health Association. We are the inclusive voice for public health here in the state of Ohio, and we work to strengthen public health as it's provided throughout the state. Especially this past 2 years, we've seen our public health districts under attack for a whole variety of things that we know to be needed in our communities. But we also want to make sure that we are promoting the value of investing in public health infrastructure. It's really critical to have our local health jurisdictions have enough money to get the job done that they need. So next slide. This issue in particular is really critical for Ohio Public Health Association because it hits on a whole variety of public health measures that I want to discuss just briefly. This issue is a racial justice and health equity issue and needs to be viewed through the lens of health and equity in all policies and all laws that are being passed. We see this as a multidisciplinary policy. As Dr. Cassim-Simo said, we need to see more work that's happening between health and oral health. Marla made a really good point about the fact that oral health is health, and sometimes we have a tendency to forget that. We see that it's really critical that the work that's being done is evidence-based, so that we're not basing our thoughts and programs on what we want to see happen, but what has worked, what can work in the future. We think that the next thing that should be true is that the work that we do really should be consumer focused. Too often do we come into communities with our programs and our ideas, and we don't really ask what's needed or how it can be best provided in the community. And so we just drop programs on top of people. They run out of money, we walk away, and the community is still left there in need. We think that it's important to have workforce inclusivity, and that means that we want to see more people of color in all of our medical and dental providers. And then we think that at the very end of the day, we ought to make sure that we're evaluating the outcome of the work that we do. And I'll talk a little bit more about that. So next slide. One of the things that we've done an awful lot of work on is just thinking about the notion of improving Medicaid reimbursement rates. So you can go to the next slide. We've done research, and in fact, some of these numbers were in the Oral Health Ohio's report that was recently released, and then also some numbers that we could find from Medicaid data that go as far back as 2012, but I don't think that it's changed much. In terms of increasing Medicaid reimbursement rates, I've reviewed a lot of the research and studies that are out there, and what I see is that while increasing Medicaid reimbursement rates has a tendency to create a little bit of a bump in terms of dental providers, if the program is not sustained, what begins happening is that providers fall off again. But we also need to do is incorporate the whole notion of who the Medicaid community is into our education programs, into our dental schools, so that the folks who are going through dental school are have a cultural awareness of who the clients are and who the consumers are, and might do a better job of reaching out to people who are in need. Next slide. I was also asked today to talk a little bit about how to address dental shortage areas by using a provider known as the dental therapist. So I want to spend a little bit of time talking about that. You can move to the next slide, please. Right now in Alaska, Minnesota, Washington, Oregon, Maine, Vermont, and Michigan, and 6 other states, dental therapists are currently providing care in underserved communities. That's both rural and urban communities, and in tribal communities. The Commission on Dental Accreditation has developed education guidelines way back in 2015. Those accreditation standards set the goal for dental education programs in the country. That means that dental therapists are being educated using the same kinds of accreditation standards that are available for dentists and dental hygienists. In 2022, a group of prominent dentists, scientists, researchers, and advocates put together what's known as the Model Dental Therapy Rule. And this identifies the best practices that are going on out there in terms of dental therapy. Now, when we've had this discussion, and Dr. Casamassimo and I have had a lot of discussions about this in the past, there are areas that are of concern to a great number of folks. And one of them is the whole area of supervision. The reality is that dental therapists don't just come into a state and operate independently. The only way that a dental therapist can operate in a state is if they are under the supervision of a dentist. The dentist hires the dental therapist. The dentist decides which procedures the dental therapist is going to be working on, and the dentist decides whether the dental therapist is going to be working remotely or directly under their supervision. And if you look at the research that's out there, you'll find that the quality of care provided to the dental therapist is on par with the dentist and with the dental hygienists. And in some cases, the dentists who are supervising dental therapists right now actually say that the dental therapist can perform certain functions better than they do. I want to go on to the next slide. So we really need to begin thinking about how do we do what both Dr. Casamassimo and Marla identified in the previous presentations. And one of the things that I've seen over the years is that when we pass pieces of legislation there very rarely are ways that we can determine whether the outcome of the new legislation or new program that we put in place are actually providing the care that we think that they should be. So we really think that legislation and rules that are being passed need to include very heavy outcome measures, very heavy analysis of the work that's being done. We think that those rules and laws should be seen through a health and equity lens. And we actually have created a tool that can help legislators know how to determine if a piece of legislation is going to have a positive, negative, or neutral impact on new laws and new rules. And then we know that the same thing needs to be true for the education of our dental providers. We need to make sure that we are giving the best education that we can that also incorporates ways for dental providers to understand the needs of the communities that they're going to be working in. And that's the end of my presentation. I thank you very much for the opportunity to present here today and for Ohio Children's Caucus making this a really important piece of the work that's being done.
Thank you so much to all of the presenters for the data, the perspective on how we are dealing with dental healthcare in Ohio for children. What we'd like to do now is open the floor, the virtual floor, to questions and answers. And so what we'd love to do is, I'll take a peek in the chat, and I saw some questions earlier that I'd like to elevate so that our panelists can address those. One was in regard to partnerships between dentists and doctors. I'm just trying to find it. The question is, can you expand more on those partnerships? This person says, we have an FQHC on site at our health department with both medical and dental services. They do collaborate, but there's an interest here to find out if there are specific strategies that can be used to expand and collaborate further. Would someone like to speak to that?
I can speak to that since I raised the issue. We actually have a project, Oral Health Ohio, which is our oral health coalition, is working on a pilot project, maybe in several parts of the state, where we bring dentists and pediatricians and family practice physicians together to create that kind of synergy and network where we can identify children at risk and get them into care. There's a tremendous amount of literature that shows that has been very successful around the country. North Carolina is probably the best example where that's been implemented, but in many other parts of the country, that's an ongoing concept. Someone, if interested, if they want to, they can contact me or contact Marla. We're both involved with this potential pilot project here in Ohio, so we'd be happy to provide more information.
Thank you so much. That's very helpful. Another question we see in the chat is a question around financial assistance and the possibility of that, or the availability of that, from state and federal government sources to integrate dental oral health records with current medical record systems. Can anyone on the panel talk about what sources of funding you may know of that have been used in the past? And also just maybe some of the logistics I'd be interested in learning about as to what kinds of possibly consultants or technology providers are needed or used. How do these collaborations work that you know of, at least here in Ohio?
I'll take a stab at that. So it's a great question, because this interoperability of the electronic health record is so important. I can't speak to federal funding for this, but there is the possibility of having some foundations, private foundations, look at this issue in terms of oral health impact investments. So I would say that would be one way that we could do that. Number two, there are some systems that are really working on this. One of them is Mercy Health System up in Youngstown is doing some work on interoperability. I don't know if David or Dr. Casamassimo, either one of you have anything else to offer.
I can just say that I'm not familiar with many in Ohio. In a lot of our children's hospitals, we do have related health records or comprehensive electronic health records. We have one here. I know Cincinnati has one, and I believe some other children's hospitals. It's a little more difficult when we have a network of private practitioners, several thousand in the state, to be able to link and who to link with. And so it's a challenge. So I think the federal government and state government would help in that regard if they could, to stimulate, first of all, the availability of those kinds of opportunities, and then to help practitioners who are interested in doing that. Some larger groups around the country, Health Partners in Minnesota, for example, has a combined health record, and as do many of our FQHCs or some of our FQHCs in the state of Ohio. So the beginnings are there. It's just we got to figure out how to make it work across the dental system.
One of the organizations that I'm involved with also is the National Coalition of Dentists for Health Equity, and they've begun a process of looking at how to create this cross-referencing between the electronic health records, doing a research paper on it. So once we have the results of that, we can make that available to people, and that'll be a nationwide look at this question.
Excellent. Thank you. I would love that follow-up and to be able to share it with all the participants.
Sure.
We'd be very interested in that. So thank you for offering that. There is a question about using mobile dentistry programs that come to schools. This participant says the school district in which I work utilizes a program. It's called SMILE programs. And the mobile dentist comes into the school building at no cost to the district to provide comprehensive dental care to students. Do we know why there aren't more schools taking advantage of these kinds of programs?
Okay, I think that's there's several layers to that. Number one, operating a dental van is very, very expensive. There are vans that are associated with, for example, FQHCs or health departments, county health departments, and then there's others that come in from out of state. So yes, it would be wonderful if we could have comprehensive services provided at every single school, but we don't have programs that reach out to all school districts in the state.
Can I ask a follow-up? Do you think that might partly be because of Medicare and Medicaid reimbursement rates? Medicaid, sorry. Well,
Medicaid reimbursement for dentists is, as Dr. Casamassimo, I think, said, it's very low. Or no, actually, David mentioned that how low the Medicaid reimbursement is. So that's absolutely a factor, regardless of what environment the dentist is working, whether it's a clinic or a mobile facility. So it's the same, and that is a real barrier in Ohio, and a disincentive because a lot of dentists come out of dental school with very high debt. The last last piece of data I saw on that was that the average dentist is coming out of dental school with almost $300,000 of debt. So you can imagine how difficult it is for dentists who want to see Medicaid patients to be able to afford to do so in a significant way that David said, that, they have a significant Medicaid practice.
I'll just add a little bit more to what Marla said. These programs, I think the ideal situation is to have a dental home with a dentist in a dental practice or a clinic. And the main reason for that is continuity. And we saw in COVID that, schools went remote. And so if that was your source of dental care, you were in trouble. That being said, the dental profession wants a dental home for every child. If it's a school, if it's a clinic, if it's a private practice, we would love to have every patient in Ohio, child, adult, special needs, whoever, elderly, have a relationship with the dentist, and that would be our goal. So however that's accomplished. The last caution is that some of these mobile programs that have come to Ohio schools will do the easy stuff. They'll do the exam and take the x-rays and maybe do some sealants, which are obviously good things. But then if the child needs to be treated, they don't do that. Now, others do, others provide comprehensive care. So a school system, my advice to them is you be very careful with these relationships, because you really want to have comprehensive care.
Thank you. I see another question here about, it's related to childcare centers. Yes. So how can childcare centers have accesses to resources to share with parents for the, I think especially since you were talking so much about early childhood and infant care, what kinds of partnerships have you seen or could there be with childcare centers to help do outreach or provide services?
So I'd like to start on this one. I was a Head Start teacher. And what I saw in my experience then is mirrored with our experience now. It's extremely difficult to find dental care for children in childcare centers. But I see that David Oshani chimed in and put in a good web link for parents to get resources. So I appreciate that. But one of the things that can happen at the local level is reaching out to local dentists through the Dentist Society or local dental groups, local dental study groups, and asking them to come to the table. Many of the child care centers, Head Start centers have meetings with parents, and I'm sure that local dentists would be interested in sitting with folks who are in need of an education about dental care. As Dr. Casamasimo said, if you paraphrase now, but if you have been without dental care for what amounts to generations, you don't know. I mean, my mom spent lots of evenings and lots of mornings herding her kids into the bathroom and making sure that we were all brushing our teeth. We were doing what we were supposed to be doing with a toothbrush in the right way. And many families, because of the crisis that they're in or because of lack of resources, that's not there. And so if that goes on for generation, it does create the point that Dr. Casamasimo was making, just in terms of fatalism about your own dental care. And so we really need to change that into a place where kids know that it's important for them to do what they need to do with their teeth early, so that they don't end up like their mom or their grandma later on. And it creates the other kinds of problems both of them talked about, which are the healthcare issues that result from lack of dental care. Thank you.
Can I just ask, could I ask you to elaborate on that? So what might that look like? You talked about reaching out to local dentists to sort of come to the table. It sounded like you were possibly referring to even sort of parent-teacher meetings. Can you just tell me a little more about what you think that could look like, or what you've seen before in terms of providing that education that you think is needed for some population?
Sure. I know that in Head Start programs, there are parent coordinator nights where parents come together with the staff of the Head Start program, and simply reaching out to local dentists in the community and asking them to come and provide education, or dental hygienists, asking them to come and provide education would be a good first step in creating that relationship between the dentist and the families.
Got it. Just sort of at least make that initial introduction.
Sure, sure.
Okay. Let's see. That's great. Wanted to also raise one of the other questions we saw in the chat. So this is a question about reimagining healthcare so that health insurance could cover dental as well as the other traditional parts of coverage that are offered. And so and part of the question is, why are these separate to begin with? Would the possibility of covering more expensive dental procedures be a factor in that? Could you speak to all those things, I guess, any of our panelists?
Sure, I'll take a stab at it. So, and we don't have the time to go through the history of this, but way back when, maybe almost 150, 200 years ago, dentistry and medicine separated and have gone along on parallel tracks. And only now in the last decade or two have we really realized that we are all together. And, you know, in Europe, dentists are trained with physicians and specialize in dentistry. So we've got a lot of recommunication and reassociation to do. There was an attempt this year or this past year to get dental into Medicare to help seniors. That didn't fly. There's a strong national movement to get adult Medicaid as a universal benefit like EPSDT or the child version of Medicaid. That is something we can be very proud of in Ohio because we've had that for a long time. So the Affordable Care Act was kind of a teaser. We thought we would get dental for all children, and it turned out that that was not the case, and that it was simply had to be offered for families to take. So we're moving in that direction. And this whole discussion we've had about an electronic health record and working with physicians and dentists together, all of that is kind of a movement to this concept of reintegrating, as Marla said, oral health is health. And you know, we're getting there. It's going to take a little bit more. It's going to cost some money probably, and have some changes in thinking, but we're moving in that direction.
That's great context. I wasn't aware that, you know, in Europe, dentistry and medical care are provided together, whereas here there was sort of a more historic split. But I think this reminds me of the conversation about mental health care as well. This idea that the brain is a part of our body and the teeth are a part of our body. And I've certainly heard more and more people ask why we don't have all of the parts of our body covered under health insurance. And I see here that Marla put a reference in the chat to a book about the why oral health is siloed. And the book is called Teeth by Mary Otto. So that could be a good reference for some of us. Another question we have is regarding, again, school-based health programs that integrate oral health. We have heard of successes in those areas, and we'd like to know if there are programs being developed across our state to expand those kinds of programs that any of you are aware of.
So yes, the answer to that is yes. There's been some federal funding to expand school-based health centers in Ohio. The challenge with the expansion of school-based health centers is that fact that there's a workforce shortage, and it's difficult sometimes when these school-based health centers are built to find an oral health provider. And that's really a challenge, particularly in our Appalachian rural communities, as well as our non-Appalachian communities. So that's a struggle. But yes, they are expanding. But the workforce shortage is definitely an issue with getting dental as part of the service.
Okay, that's good.
I just add to what Marla said. You know, we have a great program. The Oilers School in Cincinnati is kind of our flagship school-based program here at Nationwide Children's. We're involved in the Reynoldsburg schools. We have a van at Ohio State University that travels around to the Columbus City schools. So, again, these are all, kind of patched up attempts or an attempt to try to develop those systems. And so I think there is a movement forward to do that, to kind of fill the gap where families can't get a child to a dentist, or to a clinic to use the school as a basis for it. So it's growing, it's getting better.
And I have a follow-up question of my own in that regard. Is there a way that we can leverage students and or I don't know if residency is a term that applies in dentistry, but sort of, we talked earlier about the idea of the amount of debt that students have. So as far as loan programs and incentives for younger folks in the profession, or people who are maybe advanced in their training, but not yet graduated, are there opportunities to leverage those kinds of resources at some of these sites?
I'll start out there. I came here 30 years ago from Colorado, where the dental school was premised on the fact that students got a tuition break because they went to rural areas to practice after graduation. And so the federal government, our state government, offers incentives to students when they graduate, to go to rural areas. One of the tuition payback programs we have here is actually funded by dentists along when they pay their license fees. So, there is that. It could be better. I think we're all familiar with student loan issues, not in dentistry, but all the ups and downs that people have had, getting penalized and having so much debt. So there's a lot of work that needs to be done there to make us more like rewarding people for seeking these careers to be dentists, physicians, teachers. So we could do better. And in one of my last slides, or my last slide, said that this is an area where our legislature could be more active. It could really think about incentivizing young people to go out and to spend some time, like in a youth service corps of dentistry or something like that, and participate and get some of their tuition relieved. So we got some opportunities there.
Representative Smith, as you follow up on that question in particular, take a really hard look at the amount of money that's put into the loan repayment program, the number of students that have gone into it over the past 10 years, and the number of students that have stayed in the community where they ran through their loan repayment. And for us, again, this raises the question about the accountability for the programs that we run. As we're thinking about new ways of doing the work that we're doing, we can take a look at the old ways we've been doing them and make them better. So take a really critical look at the data that's there. And before I end, I wanted to make a plug for Medicare. I know this is a children's caucus, but Medicare does not cover dental care, period. You have to get a supplemental insurance program in order to get your dental care coverage. And Dr. Casamassimo talked about the fact that there was an attempt to expand dental care in Medicare this year at the national level, and it ran into some pretty stiff opposition. But the thing that I want us to focus our thoughts on is that we've seen in this pandemic that we've been in, the number of children who are now being cared for by their grandparents. It's increasing exponentially. And if the grandparents don't have care for their teeth, it's really hard for them to see how it would be good for their kids to take care of their teeth. It gets into that fatalism Dr. Casamassimo talked about. I want to really nail our heads around the fact that a large care providing group in our country does not have dental care covered.
That's helpful.
I would like to follow up on a couple of things Dr. Casamassimo said and David said. First of all, to David's point, on the amount of children in Ohio who are in kinship care is really is increasing, and the Ohio Federation for Health and Health Equity in Columbus is working specifically on oral health in this particular population, in the kinship care population. But what I wanted to also say is that, you know, Case Western and Ohio State, which are two dental schools in the state, they both put their fourth-year dental students out into the community, working in health departments and FQHCs providing care. So that's really amazing. And I know Case also has an interprofessional program that also puts, you know, the interprofessional team, medical, nursing, dentists, so forth, out into the FQHCs. The other thing I really just need to bring up is that the dental hygiene education programs, we have 13 of them in Ohio. They see a lot of patients, and we really must give them credit for being part of the unrecognized oral health workforce in Ohio. Not only are they seeing patients in the clinic where they're learning to be hygienists, but they're also required to do community education, I'm probably saying the wrong word, but they have to do community projects, which they are reaching very hard to reach populations, such as the homeless population and the nursing home population. So I just want to really raise that up, that with 13 oral hygiene education programs in Ohio, they do a lot, and they're unrecognized.
Very helpful. Well, I see we have another question here in the chat, but I also see that we're sort of close to the end of our time. So Allison, I'd love to ask for your advice on how we should proceed given the time.
I think I just see one more question, so go ahead and answer it, and then, but maybe we can make it short and sweet to respect people's time.
Okay. So someone mentioned that former Senator Peggy Lehner and Senator Craig had co-sponsored a bill on dental therapy a few years ago. Does anyone know what happened to that legislation? I have to admit that I do not. Does anyone know if there's an appetite for something similar to promote dental equity and access in this General Assembly?
Sure, I can take that one. That was a piece of legislation that was actually introduced by Senator Lehner and Senator Cecil Thomas.
Okay.
It ran through the General Assembly, had a couple of very good hearings, and then Senator Lehner went on to work at the local level, and Senator Thomas did not feel interested in introducing it again. We have looked for people who would be interested in introducing the legislation again. And it's something that we still see as being important.
I would love to talk to you about that
Okay.
after this webinar. That's very helpful to know.
Happy to do that.
Very good. So I think with that, we should look at wrapping up the discussion, but I look forward to any follow-up materials that any of the panelists would like to share with us. Allison is a fantastic resource to help disseminate those materials and stay in touch with participants. I want to thank all of the participants on the call and the panelists for sharing your time today to talk about this important topic in children's healthcare. And with that, I think we can wrap up the discussion for today. Thank you so much.
Thanks. Bye now.
Bye-bye. Have a great day.